what is the saddle nose, so we don't have the much wastage of the time on everyone regarding the saddle nose, that there is a depression on the dorsum. So really it's the challenging for the patient because you need the functional and structural correction both. This is the pre-operative workup that you have to need, like each and every patient's thorough history, understanding, structure, anatomy, and endoscopic examination. So we just assess that what amount of the settling and which material you need for the reconstruction. Pathology in the collapsed nose, either maybe you have the problem in the bony part, either you have in the cartilaginous part. Mostly in the mid-ward, you have the like post-septoplasty and like the post-infective. Mostly patients have in the mid-ward problem, and the developmental patient have the problem in the bony ward. So ultimately, what happened when there is a depression, then the nose dynamics is changed. Nose is obtuse. Nose is obtuse, and it appears just like a piggy nose. So we just discussed regarding the management protocol, and for the management protocol, like Dr. Vishal, that we usually use 3 types of the graft, like autograft, allograft, and this is the implants. Mostly we use the cartilaginous, bony, fascia, these all graft, like according to the whatever need of the requirement, septal cartilage, conchal cartilage, rib graft, whatever amount of the settling you decide. Bony graft, usually in this era, we avoid it because earlier the iliac crest and this graft from the skull, but that create a lot of pain to the patient, and the feeling in the nose is good, so they are outdated now. Mostly we use either the septal cartilage, conchal, or the rib cartilage. We not frequently use alloplastic because silicone, med, or Gore-Tex, they all have their individual problems regarding the extrusion and regarding the infection. Not physicians like the Korean, and they frequently use because they mostly have their augmentation rhinoplasty. So come to the important thing, the management protocol. So the goal in the saddle nose for correction, either we just correct the mid-wall reconstruction by different type of the grafts, or complete dorsal reconstructions. And I personally realize the problem that so many my beginner friends, they correct the dorsum and the mid-wall, but they never focus on the tip. So you need the good tip augmentation also by the different type of the grafts and fascias. So we reconstruct particularly the anterior nasal septums, we reconstruct basically the lateral crust and premaxillary area augmentation also. The problem in the augmentation rhinoplasty, when you augment the load of the nose, when you close the nose, it creates the problem. How you close? You have a good projection of the tip. How you close? So in that case, earlier like we in live case, or we also discussed routine, we put the incision on the mid-narrowest part of the columella. But particularly in the binder case, look at when you have a very short columella, then you want to increase the length of the columella. So your incision that should be V2Y manner like this, just for increase the length of the columella. So whatever amount you need the lengthening of the columella, you just incision just like the V, and then you lift up the flap, and when you close, then you undermining, and in V2Y fashion you close your incision. So now you have an extra length of this skin for increase the transcolumella flap. So if your patient have like the binder syndrome, then you can use this incision. Now we skip this one because the rest is the same. How you expose, like we discussed in the live. Now how you reconstruct the mid-wall, that is the important, because the mostly in my rhinoplasty practice, 15% I have the revisions cases. Then I realized that everyone that they harvest the rib and they put on the dorsum, they never reconstruct the mid-wall. But once you know, for a building, the foundation is mandatory here. So for the reconstruction of the foundations, you need reconstruction of the mid-wall. So how you reconstruct the mid-wall? Whatever amount of dorsal cartilage of the septum you separate from the upper lateral and the septum, and then after the reconstructions, before to reconstruction, if you have a bump, then you do the rhino sculpture, then you need a long cartilage graft by the rib. This is the extended spreader graft. So the graft could have a good foundation of the mid wall and good good support of your septal extension graft or columella whatever you use. So just as we fix like the spreader graft, fix it by a 4 OPDS suture properly. So you just need a harvest a good length of the costal cartilage for reconstruction of the mid wall. So this is the key step when you reconstruct your saddle nose, then you reconstruct your mid wall, and it's very simple. Just you use this is long. Now, how you reconstruct the dorsum? So these you have a different type of the options. Either you can use a integrated L strut, either you can use a single dorsal, or you can oblique carved rib graft or double folded concal. So according to your whatever amount of the cartilage, you just decide then which type. Suppose sometimes you have a long piece of the graft, rib graft, then you can use a dorsal straight piece. So when you put it directly, then sometimes it's displaced. This is the way, then you just pass a 5 OPDS suture and you can fix this suture in the radix area, so your terminal end of the graft is not displaced. And one another suture on the mid wall, so at least lower end of your graft is not displaced, because already the rib cartilage had a warping problem. So sometimes the rib cartilage is warped. So if you fix your graft at the two sides, like in this by a 4 OPDS suture, you have the less chance of the warping and you have the less chance of the displaced of your graft. So this is the way by the single dorsal graft. Now, what is the integrated dorsal graft? Then sometimes you need the dorsal reconstruction and you need a good tip reconstruction also. So you just prepare a dorsal graft and you make a slit, just like a V slit on the anterior part of your dorsal graft, and then this V slit just you fix with a long strut. We fix a long strut because in this slot you fix your long strut and then suture it later. So there is an integrated L strut. The advantage of this integrated L strut, then you can reconstruct both the tip and the dorsum. So in the integrated L strut, the problem is that you have to harvest a big piece of the cartilage. Then you just wrap it by the fascia. Either you can use the fascia lata, rectus fascia, or the temporal fascia. So advantage that you can suture it with the long strut graft. So this is the way by which you can use this long piece after suturing with the strut that we call the integrated dorsal graft. So you just fix it with the 4 PDS suture. Now there is another way, because if your rib is so carved, then this is the another way. Then just you do the multiple pieces of your rib cartilage in the oblique directions. This method is not for my beginner friend, because once you cut in the multiple slice, then it create again a big graft. It is the problem. But once you do the more and more pieces, then you have the no problem. So you cut it in the oblique longest direction in the multiple pieces, and then you reconstruct it again. When a patient have like this secondary nose, very thick skin in that patient, this is the suitable technique. And if you graft that is the card, then you use this one. So you again reconstruct it. You just oppose the carving and just like the namaste position. So you can prevent the warping, because there is sometimes the warping is the problem in the rib graft. What is the warping for my beginner friends? Because sometimes the rib graft is inherent tendency of the bending. So after sometimes when you put at the time of the surgery, your dorsal graft is straight, but after the sometimes the graft is bent, that we call the warping. So in this way, we fix it this dorsal graft. Now we skip. And the diast cartilage in fascia, we just use this small piece of the cartilage, we cut it, and then we just make a cylindrical tube, and we use for the augmentations. Like yesterday we see, just we make a diast cartilage, so this is the good grid of the silicone by this Medicon instrument. So you cut it in the multiple piece, and during the surgery when you carving your graft, then these all small pieces you should preserve. And the important thing, the take home message, the cartilage pieces not more than 1 millimeter, because we have the thick skin patient. This is the advantage. So if you the cartilage piece is bigger, then you know problem. Otherwise, when you are with thin skin patient, then later by the patient complain, oh doctor, I feel some thing on my dorsum. So your pieces that should be less than 1 millimeter. And then remember, this is not structural graft. This is a camouflage. This is the designing graft. Wherever you have some small depression, then you can adjust for getting the more definitions. And this have a one slot. This board have a one slot. So this is the simple insulin syringe. So you can just put it inside, and then you fill it for insert inside. So this is the advantage. Otherwise, it's very difficult to fill it because they are very small. So just like a paste. And after filling it, you just make some hole on this syringe. So just you remove, squeeze the excess water, and then you insert it. So this is the good way just to camouflage, and after closing the marginal incision at the level of the soft triangle, you can insert it and just you can use. Now, after the dorsum reconstruction, again we need the tip reconstruction. For the tip reconstruction, we reconstruct the septum and the lateral crest both, and refinement and also the premaxillary augmentations. So this is the same for the tip reconstruction. We use good long extended spreader graft and proper suturing, because when you use a long extended spreader graft, because already we don't have the septum in the post-septoplasty or something cases, then you use a big piece of the cartilage between the these extended spreader graft that we call the gap graft. So you use the gap graft, then you have a good foundation, and then you need a long big strut for getting the good definition, for good the projection. So we just put a small buttress graft behind this long strut, so that thus it prevent displace this graft the posteriorly. In such type of the assembly, we have the one problem. Sometimes the patient complain, doctor, I have a very thick, big columella. So what I'm doing that in the last, just we do the some rhinosculpture by a cylindrical graft. So the this columella thickness is short. And then this is the restoration of the anterior septum, because sometimes when your anterior septum is weak, then we reconstruct it either by a reverse L-strut septal graft or a simple septal extension graft. Because mostly binder cases and mostly post-septal plastic cases, in that the anterior septum is weak or anterior septum is damaged. So for reconstruction, you can use a reverse L-strut graft. And which type of the graft you use? It's your residual septum. Suppose you have a dorsum residual septum, then you just use this graft just as a L-shaped graft. So you just reconstruct this anterior septum. Now, for the lateral crura reconstructions, just you harvest the lateral crura strut graft and just you fix this. This is the lateral end of lateral crest. So when you put the graft on under surface of this lateral end of the lateral crust, then we say this is the lateral crura stud graft. And when you put on the upper surface, then we can say this is the Ella batten graft. I usually use lateral crura stud graft for reconstruction of the lateral crust, and then just before, yes, this one. So for this is the technique that we call the modified tongue groove for getting the more projections. That basically in this technique we advancement of our medial crust on the septal extension graft. So this is the modified tongue groove that usually we use for the projections or reduce the hanging columella or excessive columella show. Most probably we demonstrate in our cadaver dissections these all. So this lateral crura stud graft and the modified tongue groove usually use we for increase the projections, and how we fix it, this is the same. Like yesterday we fix your columella stud. Now after getting the good projections, we need some refinement. So for the refinements, we use the different type of the graft. This is the sealed graft. This is the sealed graft. So small piece of the cartilage, just like a sap of a silk, we just suture with medial crust on the both sides and little part of this few millimeter part above the dome area for getting the enhancement, for getting the good projections. This is little bit tricky when you fix it, but if you fix by the 3 needles, then it make easy. And then you can use another big butterfly graft for getting the good definition, because mostly or secondary cases, and when we have a thick skin patient, then you just always you make a big slice of graft, you prepare, you carving, and then just as a butterfly graft on either side of the lateral crust for getting the good definition you can use. But whatever graft you use, it should be fixed properly, otherwise it creates the more difficulty. And then you just do the rhinosculpture, and this another you can use the one more graft. This is the cap graft on this butterfly graft for getting the more definitions. Then the fixation of this cap graft, that is little bit tricky, but again when you do the more and more cases, then your reflexes are developed and you can use the 5-OPDS suture for fixation of this graft. But all these graft, after getting good secure, then you have the good definition. So the margin of all these graft, you just do the rhinosculpture, those that later not feel by the patient, you can use this cylindrical bar. So they all for the tip refinement graft. Now the last is the pre-maxillary augmentation, because in the binder cases the problem is that after the lot of the projections, this area is depressed because the pre-maxillary area are the deficient, anterior nasal spine are the deficient. So you can use this pre-maxillary augmentation. This is the easy way. Just you make a small incision in the gingival area, and then simple diced cartilage on both sides of the ala base junctions. You just put it on both sides. This is very simple, but you explain to the patient about this, because the patient has an edema on the lip and there is some rigidity. So it's the simple. On both sides you just insert on under surface of ala base area. So and then just by 4 vital sutures you can fix it. So for augmentation of this ala base area, you can augment this pre-maxillary area. Sorry. This is the another way. In this another way, you just put it externally and you make a cylindrical tube, big cylindrical tube of diced cartilage in fascia, and then you cut it in the between mid part, and on either side you insert it. But before cut it, you just make a suture, otherwise all dice cartilage remove, and you put it in on both sides. You put it in on both sides, so you have a very good projections in the deficient the premaxillary area. Deficient in the premaxillary area. So in this way, you can augment the premaxillary area. Plaster and tapping, I think already we discussed. I just put this simple sopratuli dressings. I usually not pack because in each and every case I use the quilting sutures. There is no need. I just put this tincture band joint. I just put this 3 piece of the steri So this is the simple. I think yesterday we seen. We skip this slide. This is the primary binder cases. Also, we just improving the results because again the primary use integrated L stud. The again use the integrated L stud. This is the 2 times operated earlier secondary rhinoplasty cases. And this is the difficult cases 3 times earlier operated, and some surgeon he make a direct incision on the tip and he put insert inside long piece 2 times, so he develop a scar. So we just on improving in 2 times operated cases earlier. These all are the surgical stage that usually we use. And finally, take home message that choice of correct surgical approach should be depend on severity of deformity, and you surgeon decide according to the deformity which material and according to the desired surgical outcome. This is my coming course. If someone wants to join, you can contact my fellowship coordinator. And this is my online presence. All my videos, cadaver dissections, and for my learning, for my beginner friends, then you can find me. And thank you again for giving your good hospitality and your love and affections. Thank you. Jai Bangla, Jai Bangla.